right. Good morning. Welcome everyone for our Grand Round series. It's a pleasure announcing a dear friend of mine, Dr. Yvonne Commodore Mensa, who is an associate professor at Johns Hopkins Schools of Nursing, Johns Hopkins Bloomberg School of Public Health, and also the Johns Hopkins Center for Health Equity. She did her PhD in nursing at Johns Hopkins University in 2016 and then a master in health sciences at the School of Public Health. Today we have a special topic, of course, one of the areas beyond the clinical domain and beyond the four walls of the health system is at the intersection of health equity, disparities, implementations, and also novel interventions that includes non-medical interventions such as with community health workers as well as other staff and mobile intervention. So as a nurse scientist and cardiovascular epidemiologist, her work has been mostly in this space, also expanding globally in Africa. She has, last year was very productive. She received the Johns Hopkins Global Health Excellence Award, and she was also endowed with the Excellence Award in Health Equity Research and Excellence Award in Research Mentoring. She's a PI of two mobile interventions, community engagement clinical trials in US and one ongoing in Africa. So we're very excited to learn from her experience on, I would say, a domain that's where the puck is going to be, and hopefully we can engage in some of those efforts too. So please, Dr. Commodore Mensa.
Good morning, everyone. Thank you so much for that lovely introduction. I am so honored to be here today with all of you, and thank you for making time to be here. I'd like to thank Dr. Nazir and Dr. Zogby for his hospitality and the entire team for facilitating my visit. And shout out to Jennifer, too, for all the work behind the scenes to make sure that my visit here was as smooth as possible. So today I'm going to be talking about assessing and addressing social determinants of health, and I want to make time at the end so we can have a conversation, because I'm sure a lot of you in the audience have things to contribute to the conversation. I have no disclosures. So here's an outline of the talk today. I'll first start by telling you about who I am, because I think it's important to understand how my background really influences the types of research questions that I pose. We'll briefly go over cardiovascular health, and a lot of you are in the audience are cardiologists. I don't need to belabor the point, but we'll talk about what we know about disparities. We'll talk about the evidence on the associations between social determinants of health and cardiovascular health. We'll talk about how to assess these social determinants and what we can actually do, going beyond just measuring these social determinants. So who am I? So I come to this work really as a Ghanaian immigrant. I moved to the US in 2004, and so my lived experience as an immigrant really influences the types of research questions that I ask. But I've also seen poverty in different shapes and forms, and I've seen the differential impact that it can have on health outcomes. So I just wanted to share that. But like Dr. Nasir said, I do have an active program of research in Ghana as well. Okay, so I trained as a nurse between 2004 to 2008 at Fairleigh Dickinson University, and when I graduated, I worked on a cardiac telemetry floor, and that's where I got a firsthand experience when it comes to really understanding what these disparities in cardiovascular health are. And so I used to take care of patients with heart failure, and after they've undergone several cardiovascular procedures, and the types of patients who would keep coming back with heart failure exacerbations were often racial and ethnic minority groups. So it led me to ask a lot of questions about, why certain groups were more likely to be readmitted than others. But then in 2010, I went back to school. I went to Johns Hopkins to pursue my PhD for 4 years, and then I left Hopkins and went to Emory for about a year. and then came back to Hopkins in 2016, where I was assistant professor. And I did something interesting, which I would not recommend again. I went back to school while I was a full-time faculty member, but I did this because I really wanted to obtain advanced skills in cardiovascular disease epidemiology. So I went back to school while working full-time, and I successfully completed in 2019, and I've been associate professor since 2022. So if I were to describe my overall program of research, it's global cardiovascular health equity, and the global is not a typo. So global meaning having local and global implications. So that's how I would describe my program of research. I'm interested in social determinants, implementation science. How do we take the evidence, the abundant evidence that exists, and actually translate them into improved cardiovascular health outcomes? But in terms of implementation science, I'm squarely focused on team-based care. How do we work better as teams? How do we leverage the expertise of different members of our healthcare team to improve blood pressure control, to improve cardiovascular health? And mobile health technology, how do we rethink how we use technology? So I see technology as a tool, right? So technology is not intended to replace a person or that human touch, but how do we use technology as a tool to improve how we deliver care? And then immigrant and global health. Like I said, I am an immigrant, and so I experienced, so in the first 6 months of living in the US, I gained about 30 pounds. And so, yes, and there are a lot of immigrants who gain a lot of weight rapidly because of a lot of changes. We talk about acculturation that happens when you migrate to a different country. So what's the goal? I think we can all, everyone in the room can agree that health equity is the goal that we should all buy into, right? And there's a difference between equality and health equity. So in terms of equity, we're ensuring that people have the right resources that they need to be healthy, and it's not just simply giving everyone the same resources. And it's also an acknowledgement that society's playing field is not level, right? There are individuals in our society who start off with a disadvantage, and unfortunately, sometimes that disadvantage carries on throughout their lives. So in terms of cardiovascular health, I'm sure everyone in the room is familiar with the American Heart Association's Life Essential 8. Recently, they introduced this metric and added sleep as one of the metrics to monitor. That's also important. But they also did something different, which is to actually acknowledge that we can't get to cardiovascular health without also addressing the connection between the mind, the heart, and the body, right? But so talking about psychological health and well-being, but we also need to address what the underlying social determinants of health that impact cardiovascular health. And we also know that there are profound racial and ethnic disparities in cardiovascular health. So when you think about health behaviors, whether it's diet, nicotine use, physical activity, sleep health, there are these disparities. But when we think about health factors as well, so diabetes, hypertension, high cholesterol, these disparities are well known and have been studied and described. We've done a great job of talking and describing these disparities. But what do we do with this information? We also know that there are disparities in cardiovascular disease mortality. Things have gotten better because of improvements in treatments and novel therapies, but unfortunately, there are persistent disparities, racial disparities in cardiovascular health, where Black men are more likely to die from cardiovascular disease than white men, and similarly for Black women as well. So again, what do we do with this information? So I think we've also changed how we talk about disparities. And I remember when I took cardiovascular disease epidemiology as a doctoral student, it was actually demoralizing. Every week you would hear Black people are more likely to have hypertension, diabetes, kidney disease. It was just, and this was in 2010, no one at that time took time to explain that. It's not because of their skin color. The reason for these disparities are what? Underlying adverse social determinants of health. So I think we've changed, or we're doing better about how we talk about these disparities. So what are these social determinants? So they're the conditions in which people live, learn, play, work, pray, right, that influence their health. And Healthy People 2030 has identified these social determinants in terms of education access and quality, healthcare access and quality, neighborhood and built environment, the social and community context, and economic stability. So again, we are accepting that these social determinants are the root causes, right? It's not skin color, because I question whether I was bound to develop kidney disease, diabetes, because I was a Black person. But really, these social determinants are the root causes of these health inequities. So in 2015, the American Heart Association published this nice paper that outlined key social determinants that were associated with cardiovascular disease. They highlighted race, ethnicity, and racism. In most cases, when we talk about disparities in healthcare, there are reports, there are studies that have shown that there are patients who feel that they are not treated fairly and equally in the healthcare context. And they also highlighted in this paper social support, culture and language, access to care, and residential environment. But they also went a step further, and I think a lot of us in the health equity space were shocked when the statement came out, because for decades when we talk about these disparities, we try to avoid the R word, right, which is racism, right? But the AHA took this bold move to highlight structural racism as the root causes of these disparities. So these are the policies that really perpetuate some of the differences that we see. So economic policies, educational policies, who has access to certain opportunities and who doesn't. And these are not natural. They are man-made differences. So it was really a bold move by the AHA when they put out the statement. So how does structural racism play out in our society? I think we can all accept that, unfortunately, your zip code is a better predictor of your health than your genetic code. I'm sure a lot of you have heard this expression. So let me just walk you through a tale of two neighborhoods in Baltimore. And I think you can think about Baltimore, but you can think about several neighborhoods in Texas too. So every time I give this talk, I think you can easily apply this to a different context. So one of them is the Greater Roland Park area, and the other is the Clifton-Berry area. And Johns Hopkins is located very close to the Clifton-Berry area. So ideally, if you live closer to Johns Hopkins, you should have better health, right? World-class institution. So what if I told you that in the Greater Roland Park area, only 5% of the residents were Black people, and in the Clifton-Berry area, it was 95% Black people? Would you be able to predict their health outcomes? Sadly, yes. So these are the numbers. So there's a 17-year gap in life expectancy, and these neighborhoods are only 5 miles apart, right? That is unnatural. That you'll see, and what I usually say is the life expectancy of residents in the Clifton-Berry area is very similar to a lot of African countries, right? And so we talk about global health and how these global health disparities exist. And right here in the US, we have neighborhoods where the life expectancy is only 67 years. And when you think about some of the reasons for the difference in life expectancy, look no further than the social determinants. Look at the difference between high school graduation, the unemployment rate, the hardship index, which is a composite index of a lot of different measures in terms of education, income, the percent of land covered by green space. So when we talk about social determinants, sometimes we focus on the bad, but there are also the good physical and environments that we want to promote in terms of the percent land covered by green space. And in the Clifton-Berry area, only 12% versus Greater Roland Park is 64%. Right? But like I said, this can easily be applied to different contexts. So why should clinicians care about social determinants? Unfortunately, we all are affected by this. There are direct and indirect effects. Just highlighting this paper by Eric Brandt, that did a nice job of talking about how these social determinants of health directly and indirectly impact health outcomes. And this is published in JACC, and it's a pretty nice paper. And another reason why we should all care about this is that we all pay for this. right? That's a nice study that was conducted by the NIMHD that estimated the economic burden of health disparities. And does anyone want to guess what that number is? The total number, the cost of these health disparities in 2019? $451 billion, right? That's a lot. We all pay for it. But unfortunately, this burden is disproportionately borne by racial and ethnic minoritized populations. You can see 69% for Black and African American people and 21% for Hispanic people. So that's why we should be pretty involved in advocacy efforts to also ensure that we eliminate these disparities, because these disparities show up, and these adverse social determinants affect how someone's able to adhere to prescribed therapy. And it also influences when someone shows up or who doesn't show up. Another question that I often ask is who's missing when we look at our data? Who's not showing up at all because of the way our healthcare system is structured as well? And on the right, you can see there are 5 states with the highest burden, and these states are also the most populous states. So number 1 is what? Texas. So this is also an interesting statistic. So I wanted to highlight the systematic review that our team conducted. It was led by one of our rockstar PhD students, Faith Metlock. So we conducted a systematic review to understand the associations between social determinants and hypertension. It's currently in review in the AHA Hypertension Journal. We found 57 studies that met the criteria, and no surprise here that individuals with higher educational attainment, individuals who had greater economic stability, had a higher odds of blood pressure control. But unfortunately, fortunately, those who lived in a more favorable neighborhood environment had a lower prevalence of hypertension. I know some of the numbers are hard to see, but I'll verbalize them as I go along. So our team also conducted a systematic, actually we analyzed data from NHANES, the National Health and Nutrition Examination Survey. And we wanted to also understand the same question: what is the association between social determinants and hypertension outcomes? So we analyzed data on about 21,000 adults, a mean age of 47 years, 51% of them were female. And these are the factors that were associated with a lower probability of controlled blood pressure. And again, no surprise here, we know about the racial disparities, but I want to highlight 2 that are also important. Not having a routine place for health care. Right? We talk about why blood pressure control is not achieved, but unfortunately there are individuals who still don't have a routine place for health care. And I remember when I moved from Maryland to Atlanta and I wanted a primary care provider, I was told I had to wait about 4 or 5 months to be able to be seen. And so how do we think about team-based care approaches where people can be seen sooner and have a routine and consistent health care? And not having health insurance. Again, this is a larger societal issue that we continue to grapple with, and it also differs by state in terms of policies and resources that are available. But it's healthcare is a fundamental human right, but unfortunately, there are individuals who don't have access to basic healthcare. Another social determinant that I want to highlight is place of birth. Right, so this is an elegant paper that Anile Shah and colleagues conducted, and they wanted to understand racial and ethnic differences in cardiovascular health. And they identified that education explained the largest component of the cardiovascular health difference between Black and white females, but also place of birth, whether or not you were born in the US, explained the largest component of cardiovascular health for Hispanic and Asian females. So the point is that when we think about social determinants of health, for those who are not born here, that may also influence their health as well. And so another key takeaway as you consider social determinants is that migration itself is also a social determinant of health, because there are individuals who prior to migration may have masters and PhDs, and you arrive in the US and what happens? a lot of those credentials are sometimes not recognized, and you have people who face a lot of challenges in terms of integrating in the US society and the healthcare system as well. And we know that the US is changing, right? And even as we look around the room, how many of us were not born in the US? Wow, a sizable proportion. So the saying goes, the US is a nation of immigrants, but the distribution of immigrants is also changing. In the recent years, a higher proportion of immigrants are more likely to be African-born and born in an Asian country. So, and this is also relevant to the state of Texas, and I think there are pretty sizable populations of African immigrants in Texas as well. Another study I wanted to highlight, our team analyzed data from the National Health Interview Survey. And when I talked about my experience in the cardiovascular disease epidemiology course, and one of the questions I asked was, yes, I'm Black, but I wasn't born here. When you think about the health outcomes of those who are born here versus those who are not, what are the differences in health outcomes? So we analyzed data from NHIS, the National Health Interview Survey, and we wanted to understand if there was a difference in hypertension and diabetes, but also the underlying social determinants of health. And what did we find? We found that African immigrants, 34% of them had a college degree, compared to only 16% of the African Americans. So we compared African immigrants to African Americans and Afro-Caribbeans. And then we also wanted to understand, is there a difference in health insurance status? So while 82% of African Americans had health insurance, only 73% of African immigrants had health insurance. So that's something to also consider within this context in terms of who has healthcare access and who doesn't, and how does that influence health. So we also acknowledge that there wasn't a lot of data on the African immigrant population, so we conducted a cross-sectional study in the Maryland, DC area, and we recruited about 425 African immigrants from Ghana, Nigeria, Liberia, Sierra Leone, and Cameroon, and they had to be at least 30 years, and they had to be born in one of these African countries. And one of the papers I'll highlight is a paper that was led by Dr. Bumi Ogumbe, who's assistant professor at Johns Hopkins. And so we looked at the associations between social determinants of hypertension and diabetes, and we found that the odds of diabetes were 5 times higher among those who were unemployed. And I think we've talked about these key social determinants, but in this study we found that in this African immigrant population, being unemployed was associated with a higher odds of diabetes. Another interesting finding, we also stratified the data by where people were born. Again, as can be said for even Asian immigrants, it's not a homogeneous group. So we stratified by where people were born, and we found that African immigrants who were born in Liberia had a higher prevalence of hypertension, diabetes, and comorbid hypertension and diabetes. So another key consideration is, as we think about how we examine these disparities and social determinants, not assuming that populations are homogeneous, right? We need to take a step back and really ask the right questions, but also stratify data to understand where health outcomes may differ, as well as factors that are associated with these outcomes. So what do we do about these disparities in immigrant populations? And the WHO published this World Report on the Health of Refugees and Migrants, and they made a number of key recommendations that I'll highlight. And one of them, which is pertinent to our conversation today, is we need to train clinicians and health systems to address social determinants of immigrant, or the social needs of immigrant groups. But more importantly, we need to design and implement what cardiovascular health education programs that are targeted to these diverse immigrant groups. So now I've talked about the evidence in support of examining the associations between social determinants, but how do we actually measure them? Okay, so how many of you have heard of the county health rankings? A few, yes. So if you want to understand data on the health outcomes of counties, as well as these social determinants, the county health rankings is a great resource. And so this is an example. So you can go online, just look it up and enter a county name. But Baltimore City is unique. It's different from Baltimore County. So comparing Baltimore City to Houston, you can see, you can actually compare counties too. If you're considering moving to a state and you want to know the health outcomes of residents in the county, it's a great resource. So you can see that there's a difference in the trends in premature deaths in Baltimore City and Houston. We can see that although there's a decline in premature deaths in both locations, there's been an uptick in premature deaths also in the past decade as well. And then we also have the City Health Dashboard. How many have heard of the City Health Dashboard? Fewer. Okay, great. So I'm doing my work. So the City Health Dashboard provides more granular data on cities. And so if you just look it up, cityhealthdashboard.com, you can enter a city name. And one of the great things about this resource is that it's targeted to local leaders to also help them to have access to the right data, but also to think about how to target and invest in cities to improve these health outcomes. So just to show you an example, if you go online, you can search for different health outcomes from cardiovascular to disease deaths to hypertension, but you can also look at social and economic factors, including income inequality, high school completion. You can look at health behaviors, and they also have data on clinical care. And so they have data on over 365 large, medium, and small cities in the US. So I wanted to show you an example. So they do have 37 measures of health and the social determinants. So for Baltimore City, it's actually really hard for you to read in the back. For cardiovascular deaths in the US, it actually shows you how a city compares to the average for the dashboard. You can see that for the dashboard is 201.5 per 100,000 deaths, but for Baltimore City is 252.6. But for Houston, Texas, it's slightly worse than the average, but better than Baltimore, where it's 237.3 deaths. So I'm sharing this resource because as we think about social determinants, this is a great resource to understand neighborhood or community level social determinants as well. And so there's also the Phoenix Toolkit. As you're thinking about different measures of social determinants, the Phoenix Toolkit, and if you're applying for a grant, an NIH grant, please definitely recommend that you're going to use measures from the Phoenix Toolkit. It has 23 protocols on different social determinants, but they also have data on structural social determinants of health, including the Social Vulnerability Index. And so you can go in there and select one of these tools. And so beyond the neighborhood level measures, there are also individual level measures of social determinants of health. And so there's this great resource that was developed by the UCSF team called Siren. So it also has different ways that you can measure social determinants of health. It has different tools and specifies which populations you can use these tools for. And one of them is the Accountable Health Communities tool, the CMS health-related social needs tool. And this is actually the tool that our team is using for 2 of our trials in the Baltimore, Maryland area. So if you only were interested in the core domains, the 5 core domains, there are only 10 questions. So those 10 questions can be administered pretty rapidly. But if you wanted to understand additional domains in terms of financial strain, substance use and physical activity, there are supplemental domains that you could include. But if you wanted to just do the basic measure, there are only 10 items in there. And so I would be also remiss if I didn't mention Z codes as well. And I know yesterday at dinner I was asking, to what extent are Z codes used, and how many of you have documented or used Z codes or have heard of Z codes? Just a few. So because we are acknowledging that these social determinants are important, there are 10 Z codes, ICD 10 codes that are used to document social needs. And so if you really want to quantify the impact of social determinants, we have to have a standardized way of measuring them. So for Medicare beneficiaries, This is highly recommended so that we can actually, and it shouldn't just be for Medicare beneficiaries, it should be for everyone. So for me, it doesn't matter what you use, it matters that we find something that is practical, quick to administer, but is used consistently. But there was a study that was conducted to understand to what extent these codes are used. So I'm going to ask you, in 2019, what % of Medicare fee-for-service beneficiaries had claims with Z codes? What percent? 5, and 1.6. 1.6.
And they've always been here?
So the Z codes?
Yeah.
So they started in 2016, or a little earlier than that. But in 2016, they found that it was only 1.3%. So there was this much of an improvement in 2019. Granted, that was 5 years ago. So I tried to find a paper that reported more updated numbers. We don't have those yet, but I would be shocked if it was more than 5%. But again, it shows that there's a lot of room for improvement if CMS is recommending the use of these codes and they are not being adopted. The questions are, why are we not adopting them? What are the issues? What are the concerns? And how do we make it easier? Did you have something to?
First is awareness.
Awareness.
If you look at this room here, many of them are practicing physicians. I was not aware of Zika.
So we'll have to have an info session on, on how those may be used. But so for instance, you can specify a code if a person is experiencing homelessness, right? So again, if we were to do this consistently, imagine, and I understand that you use the social determinants wheel, but again, wherever there could be alignment, again, that would be excellent. Okay, so once we collect all of this data, the neighborhood level data, individual level data, what do we do with them, right? And I think that's the million-dollar question. These data can be integrated into the point of care and also panel management, understanding which populations are at highest risk, not just in terms of their pulled cord equation score or overall cardiovascular disease risk, but in terms of their social needs. Who should we invest resources in terms of making sure that they have access to a social worker, community health worker. So this is an excellent paper that also talks about how we can integrate these social determinants of health data into workflows. So ideally, these data should be used to trigger referrals, right, to social work and also should be integrated in clinical decision support tools. And if we do this right or get this right, it should yield improvement in health outcomes. And so ultimately, if we integrate these data, we should also find ways to connect patients to the resources. I always say, why measure social determinants if there isn't that additional step of getting people the help they need? It's unethical if you're asking people about all of these challenges and you have no plans. So before you actually measure, have a plan of what you're going to use the data for. And also data for advocacy, right? A lot of these issues are socially and economically determined. And so how do we show up as healthcare professionals in terms of policy efforts locally and nationally to ensure that these issues are addressed, and also, like I said, risk stratification. So the last segment, I'll talk about how to actually address social determinants, and I'll share our experience from one of our trials, the linked BP trial. So the linked BP trial is part of the larger RESTORE network. So RESTORE stands for Addressing Social Determinants of Health to Prevent Hypertension. So in 2021, the American Heart Association did something different. It said, we've invested a lot in interventions to control blood pressure. How do we actually focus on the prevention of hypertension? So the AHA funded this network that's led by Dr. Benga Ogedebe and Tanya Spruill and NYU. And it's a network that consists of a number of institutions you can see on the slide, and Johns Hopkins is one of them. And so we had to propose a network that would include 5 separate projects that will discuss interventions or present interventions to address social determinants of health. And I'm honored to be one of the project PIs. So what does linked BP stand for? It stands for home blood pressure telemonitoring linked with community health workers to improve blood pressure. So I'm also honored to lead a wonderful team with one of my mentors, Dr. Cheryl Dennison Himmelfarb, and some of you may know Dr. Lisa Cooper. But we have an incredibly diverse team of clinicians, students. We have trainees at the predoctoral and postdoctoral levels as well. So our study aims to examine the effect as an implementation science project. We're examining or comparing the effect of the linked BP program, and I'll talk about the intervention components to enhance usual care among people with elevated blood pressure or untreated stage 1 hypertension. I mentioned earlier that we have a lot of interventions to control blood pressure, but not enough to prevent hypertension in the first place. So for those whose blood pressure is slightly elevated, who we know in a few years, they may progress to stage 2 hypertension if we don't intervene. How do we intervene? By addressing social determinants. So we're doing this work in community health centers and primary care clinics in the Maryland, DC area. So our primary aim is focused on really systolic blood pressure reduction, but we also have a secondary aim that's focused on the implementation outcomes, the reach, the maintenance, the adoption of the intervention, and the cost effectiveness. So we actually going to be tabulating the different costs in terms of the community health workers, their time, the blood pressure devices, so in terms of informing policy work as well. So there are 20 sites that are randomized, 10 on the enhanced usual care and 10 in the linked BP program arm. And participants can be Black, white, or Hispanic. And once they're consented, they do the baseline assessment, and the follow-up times are 6, 12, and 18 months. And the primary outcome, like I said, is systolic blood pressure reduction, but there are other secondary outcomes that we're interested in as well. So what is the linked BP program? So we know that there are multiple determinants when we think about blood pressure control, right, at the patient level, provider level, health system level. So as we consider interventions, these interventions should also be multi-level, and there are studies that have shown that multi-level interventions are more effective than interventions that just address one domain. So our intervention includes home blood pressure monitoring, right? So patients or people who have hypertension shouldn't wait 6 months to have their blood pressure measured. Ideally, if someone is diagnosed with hypertension, they should have a validated blood pressure device. Then we also know that technology, like we said, a lot of people have smartphones. How do we leverage smartphone technology and apps to improve the monitoring of blood pressure? We also trained all the practices on accurate blood pressure measurement because we're using the clinic BP measurements for our study outcomes. We didn't want to come in and really disrupt the care that was being provided, so we wanted to standardize blood pressure measurement. So we go into all the clinics and train them, and in some cases retrain them on blood pressure measurement. And education and counseling on lifestyle management. So we know food is medicine, exercise is medicine. How do we educate patients on adopting healthier behaviors to prevent hypertension, as well as community health worker visits. And I'll talk more about the community health workers shortly. So like I said, we're using a mobile health app called Sphygmo. So it's currently available on the Google and Apple stores. It's free. And it's also available in 4 languages. That's one of the things I really like about this app. It's available in English, French, Spanish, and Mandarin Chinese. And so the app integrates, the other thing I appreciate is that the app integrates with all validated blood pressure devices. So I hope you've heard of validatebp.org. So it's a site for really reviewing the list of validated devices, because there are a lot of devices out there, not all of them are validated. So as long as the blood pressure device is validated, it can integrate with the app. So we've chosen to use an Omron 5 series, but we also have an Omron 9210T for those who need an extra large cuff. Because again, people should have the right cuff to ensure that the blood pressure measures are accurate. So there's a patient portal, there's a patient-facing app, but there's also a provider portal that allows us to review blood pressure measures remotely and see trends. You can see a 3-day average, 7-day, 30-day average remotely as well. And the other neat thing is if you were to go to a pharmacy and they have a kiosk, because we know there are blood pressure kiosks in a lot of pharmacies. If the kiosk is validated and you measure your blood pressure, you can also sync the readings in the app as well. So we've engaged 20 sites. One of them, actually 2 of them, are designated as federally qualified health centers, Choptank and Unity, but also we are recruiting patients from Johns Hopkins Community Physicians and LifeBridge Health in the DC, Maryland area. So these are some preliminary data on the 181 participants. This was last week. We now have about 200 participants. The mean age was 42 years. 27% of them are Black adults, and 25% of them are Hispanic, and about a third of them were not born in the U.S. or considered immigrants, and about 50% of them have at least a college education. And so, as you can imagine, doing this work takes a lot of recruitment. It's been a fun journey. We started this project in 2021, again, in the thick of COVID, so just engaging people, calling them on the phone, telling them about the project. And what's also different about this study is these are people who have not been diagnosed with hypertension, right? So calling them and telling them, well, technically you don't have what you consider stage 2 hypertension, but your blood pressure is high and it could be better. So just trying to educate them about the importance of, blood pressure, improving blood pressure with lifestyle management. So we've had to employ a number of strategies to boost recruitment. We've created a study website, linked-bp.org. We've also started recruiting participants through patient portals. So My Chart for Hopkins, which is an amazing resource. I don't know if you have a patient portal for recruitment for studies. That has made such a difference because they're getting the message from the health system. They're more likely to trust it than just getting a cold call from our team saying, hey, we want to help you. In most cases, sometimes people think we're telemarketers or trying to get something from them. So we're still trying to overcome those challenges. We also have, like I said, a study website to help garner interest in the study. So I mentioned earlier, we have community health workers on our team who are actively intervening. They are the true rock stars in this study. There are 4 of them that we've hired so far, and they are conducting baseline and follow-up visits and really assessing and addressing social needs. How are they doing that? So at baseline, we're using the CMS social needs tool that I mentioned, and so that tool gives us data on what their social needs are. Does someone have issues with transportation, with housing? And then they use this information and find resources using Find Help. Has anyone heard of Find Help or Unite Us? So these are platforms that exist. If you put in a person's zip code, it can give you a list of resources to address housing, if someone needs help with employment, right? So they are actively intervening to link people with the right resources. And so this pie chart shows the types of social needs that they're addressing so far. So in green, you can see transportation needs. That's like almost 17% of the issues that have come up are regarding transportation. Food insecurity. We tell people to eat healthy, 5 servings of fruits and vegetables, and there are people who don't have access to food at all. So they are actively intervening and addressing these issues. And we can't do this work alone. We have stakeholders that we've engaged throughout the project. We have a community advisory board that provides feedback on our materials. When we drafted the study website and recruitment videos, we showed them the videos and they were honest. They gave us feedback, told us how to improve those videos. We've also presented at the health systems to get buy-in from providers, clinicians, because we can't do this alone. If they know about the study, understand the importance of it, they're more likely to refer. And we've been very fortunate to have had referrals from primary care providers who have bought into the study. And on the bottom, you can see some of our trainings. We've gone into the practices to train them to use the clinic BP devices. And we also assembled a team and had a health fair at one of the practices. The turnout wasn't the best because apparently there was a NASCAR festival or something the same day. That's what we're competing with. So, but we were able to assemble a team of actually it was 20 of us, And just to give you some context, the Choptank Denton practice is actually an hour and a half away from Baltimore. So we all got in a van and we drove there, and the goal was to screen for blood pressure. We also checked people's cholesterol, so that was the goal. So that's another way to give back to the community. So we didn't do that just to get those measures, but to increase awareness about the project. That was one of the goals, but also to serve the community as well. And in terms of dissemination, we have a steady newsletter. So, and that's our way of keeping our stakeholders engaged, to tell them about the project, the work that we're doing, giving them updates on recruitment, how things are going. And one thing we are actually implementing is getting testimonials from participants, asking them what's going well, what tips do you have, and so we can share those testimonials with people who are on the fence about participating in the project. So we're really fortunate that our team has come up with this idea of this newsletter. We also have a provider newsletter that has information that is targeted at providers of their new guidelines, their new statements that have been published that we think would be relevant to them. So again, it's another way to engage with clinicians on our team as well. And I'm wrapping up here, but like I said, and I think I've alluded to a lot of these things previously, but in terms of how we think about integrating social care into the delivery of healthcare, it's not a thing that's nice to do, it's a must, because these issues get in the way of achieving optimal health outcomes. But the last point that was highlighted in this NASM paper is that we need to fund, conduct, and translate research and the evaluation and the effectiveness and implementation of social care. So yes, we know that it's important to address and assess social needs, but we don't have a lot of evidence that if you address those social needs, does it yield improvements in blood pressure control? Does it prevent cardiovascular events? So they really called for more studies to address this gap in knowledge as well. And I would be remiss if I did not highlight our wonderful lab, the Global Cardiovascular Health Equity Lab. A lot of them are really studying different issues that pertain to social determinants of health. For instance, Faith Metlock is looking at social determinants of cardiovascular health among Black and Hispanic women. But Brooke Tishomi is looking at multi-level modeling of social determinants of health using data from the City Health Dashboard as well. And also want to highlight my wonderful mentors. Really, I give them credit for allowing me to think outside the box and doing some tough things, and also helping me to know when to say no to certain opportunities so I can be more productive. But I always say a mentor is not someone who walks ahead of you. They walk beside you and they show you what you're capable of doing, and I'm very grateful for their support. And with that, I'd say thank you for your time and attention.
All right, so what a wonderful talk. Thank you for sharing your journey, but more importantly, I would say challenging all of us to think beyond the usual, what we do within the four walls of the health systems, and how health is affected by many other things, if truly the aspiration is achieving health rather than just disease care. We just have to broaden our scope. So I'll just start with a couple of questions. From health systems perspective, of course, most of our work still happens within the four walls of the health system. What are the key components in your mind would be needed to build an infrastructure that not only, as you said, it's not only about the capturing, but capturing is important, but what type of infrastructure in your mind would be needed to help eventually then take that information and potentially impact disease and health?
Thank you for that question. The first thing I'll highlight is community health workers. Do you have community health workers integrated? I'm a huge fan of the work they do, because even in the Link BP project, one of the community health workers told us recently, when she talks with the participants, they're just so grateful because they feel that, that 15-minute encounter where they just have to talk about things quickly and just go, does not give them enough time to really tell their story and talk about what's going on. And these community health workers, sometimes the visits last an hour. And you can get a lot in an hour. And so they're also going a step further. So as much as we can invest in the training and also the advancement of these community health workers. So in some cases, a lot of community health workers are supported by grants. And so when the funding lapses, then they go away. But to have that high-level institutional support that says, we value community health workers, they are part of us, that we see them as an extension of us in the community, that's one of the best investments that can be made. But also equipping the community health workers with the tools that they need. How can they also use technology meaningfully to connect people to the right resources?
That's perfect. Any questions?
Thank you for coming and for sharing your thoughts, your journey, which is very inspiring, and the work that you're doing, because it is an eye-opener for many of the physicians. Not that we don't know of many of the factors of social determinants of health, but their complexity and the complexity of action that you have spearheaded, which is really amazing. So the question to you is, one, interesting that you went for early prevention of blood pressure as opposed to another issue which is quite prevalent too, adequate control when somebody, and the question is why. Two is, share with us maybe something else in the nation that is ongoing regarding addressing social determinants of health. And in those various determinants, which ones are the low-hanging fruit versus the ones that are very difficult to address?
Okay. So I think the first question was about why we made the choice to focus on prevention. So we actually have two trials. One of them, LINK-BP, is focused on the prevention of hypertension. I didn't have enough time to go into Linked Hearts, that's focused on controlling hypertension among those who have stage 2 hypertension plus diabetes or stage 2 hypertension plus CKD. So they are also an important group to address, and our intervention is fairly similar in terms of engaging community health workers, but we are adding a pharmacist. So because these are individuals who have multiple chronic conditions, and a lot of them are taking a lot of medications, and so medication and adherence is an important issue to address. So that intervention is also similar, but includes a pharmacist. So we think it's important, but we clearly are not investing enough in prevention, which is ultimately, we're hoping that it pays off, that if you can prevent in that progression to stage 2 and even educate people about the fact, and we're always blown away when people don't realize the simple things that we consider simple, like, well, if you eat a can of chicken noodle soup every night for X number of days, eventually your blood pressure is going to creep up. How to read food labels, the relationship between obesity and hypertension. So all of that education, if we equip people with that knowledge, they can hopefully change their lifestyle. And we know that there may be people who may progress, right? But we're hoping to demonstrate that a lower proportion of people in the LINK-BP arm will progress to stage 2 hypertension. So I believe that was the first question. The second was about social determinants and which is the low-hanging fruit. I think that's a tough one. And so I'll answer it this way. The things that we can do as a society and the things that Houston Methodist could do, right? So as a society, everyone should have health care access, period. Basic, we're talking about once a year screening, you have high blood pressure, everyone. Until we level the playing field and ensure that everyone has that basic access, we're gonna keep running into these issues where we're just putting Band-Aids on issues. So that's what we should do ultimately as a society. But in terms of healthcare systems, and not just Houston Methodist, it's also reconsidering how we offer care to make it more convenient. Why do I say that? We ask a lot of people with hypertension to take time off or drive for a 15-minute visit. And if you have hypertension, It's a silent killer. You can't tell when it's high. You just go about your business. How do we make care more convenient and also bring it to their homes, right? So improving healthcare access, and healthcare access not just being the insurance part, but having access to someone who's qualified and skilled to be able to intervene at the right time. So we think about our hours, right? The 9 to 5, right? Some community health centers are being really innovative in that space and offering extended hours and going till 7 because they know that they will get individuals from 5 to 7 who otherwise may go months and years without seeing a provider. So how do we think creatively about how technology may even be brought in the home, remote monitoring, right? But the key is once you have those technologies and tools, how do you integrate it back, right? So everyone on the team has access to the data at the right time.
So I just want to acknowledge you because I feel this is really, somebody said soulful work. Do you know what I mean? That this is about why we're all in healthcare. I think that we want excellence for patients, but we also want them to have what they need. And there's so many things we've been ignoring. So I really have been inspired by your presentation. The question that I had, because you've been working in Baltimore, is Houston Methodist is a city that Hispanics are going to almost become the majority in the next, 10 years or something like that. So I wondered if you could speak to kind of your thinking about how this work will translate, what work needs to be done, what's different, knowing that that's our largest minority community, fast becoming the majority.
Yes, no, that's a great point. And when we were designing the study, the other projects in the network are only recruiting Black people, right? So it was supposed to be focused on, Black populations, but we had to make a strong case for not just including Black people, but also when you think about these community health centers, there are people who are living in poverty who are getting care. So anyone and everyone should be getting access, even though it doesn't include the whole population. We thought would be important to include immigrants and Hispanic populations. So one of the things we did was on our team, we hired 2 research assistants who are students, but are bilingual. And let me tell you, in terms of recruitment and the success we've had so far, a lot of people are shocked at how effectively and quickly we recruited Hispanic people. Is because our team reflected the population. So what am I saying? That as we think about how the US population is changing and how the patients that we're serving continues to evolve, we also need to ensure that our profession resembles, the population that we're serving. How do we get more clinicians, so nurses, pharmacists, cardiologists, primary care providers who, are of Hispanic origin, because it makes a difference. Because I saw it play out. We went to Chop Tank to recruit, and one of our team members who's bilingual couldn't be there. But we approached and we started, we tried to use Google Translate, failed miserably. But then we called this gentleman on Teams and we said, hey, can you talk to this person? And immediately she lit up and she's like, yes, I'll do it. What do you want? What do you want? So it makes a difference. We can't pretend that it doesn't. So I think that's one of the things that could be done in terms of how do we think creatively about supporting people who have aspirations to get in the healthcare profession and, being exposed to different people in the healthcare profession to show them what's possible.
Dr. Mensa, I just want to congratulate you. Such a wonderful presentation, so inspiring. I have 2 quick questions, and this is coming from someone who has been in the SDOH space working, of course, under Dr. Nasser's vision for a few years now. And so, work that you're doing is just inspiring and fantastic. 2 quick questions. One is, you mentioned how we can hopefully integrate SDOH into our clinical workflows, right, to inform clinical decision support systems, right? But at the same, and I think this is what Dr. Nasser and I have been sort of grappling with as well in terms of, one of the ways that we think could potentially be done is developing some sort of polysocial risk scores, right? And what could potentially be the next step, right? But at the same time, when you develop these scores, you validate them and you think about integrating them, right? There's also a resistance from the healthcare system, right? In terms of the existing workflows and how do we integrate something that is not inbuilt into the system originally, right? So I guess my first question to you is, how do we overcome that resistance, right, from a healthcare system perspective? How do we change perceptions around thinking about SDOH and integrating them into workflows as not a disruption, but rather, a tool that can potentially help clinicians, better screen, identify, and address SDOH? So that's my first question. And then I guess my second question is, again, fantastic work on the boots on the ground, real work, community level, community-centered work. Dr. Johnson and I, of course, currently working on a PCORI grant, kind of similar. But I guess, my thoughts, in terms of working with, large community-based agencies, training community health workers, I think the end goal there is, should be, I guess, is developing some sort of a, social support resource tool or a bank, that can sort of, identify and pool community social support resources by different levels of geography, right? So for example, we are working with, 10 or 12 different CBOs in Houston, but it's very hard to identify a particular CBO that can address a specific SDOH, right? So I think the end goal for us as scientists and as providers, should be to create some sort of a tool or a bank that can potentially be used long-term, right? So just wanted to get your thoughts on that.
Yeah. So I'll answer the second question first because it's easier. Then I'll think more about the first question. So in terms of tools and resources to address these social needs, I think I mentioned Find Help and Unite Us that are trying to do what you described exactly, which is that we know these domains of social needs. You go on there, and some health systems are actually integrating Unite Us into their platform. So once you identify a social need and homelessness comes up as an issue, that it also generates here a list of 5 community-based organizations that address housing stability, right? Similarly, if it's financial toxicity, and someone needs employment support. So there are health systems that are doing that, but as you can imagine, everyone decides which ones they want, and there's no gold standard. And ultimately, the decision is made about which is, practical, cost-effective. But again, related to that, I think we haven't done a great job of, yes, if those needs are addressed, right, do you ultimately, if someone has uncontrolled blood pressure, you identify this need and you link them with this resource, how do you close the loop? Was it effective? So just because someone's referred to a service doesn't mean they're going to get it, that they're going to be satisfied with it, that it's going to be effective, and does it ultimately improve their health? So it's challenging, but I know there are some tools that exist, but they could always be better integrated. The first one was about how do you convince, or how do you get that buy-in from health system leaders to adopt? And shout out to Dr. Nazir for the Paul social risk. I didn't mention it earlier, but we need more of those index measures that combine different domains, right? To understand, if you have 5 or more of these needs, like how does it translate into cardiovascular health outcomes? So I can share sort of some of the conversations that I've been part of where it's like, well, we are already using this and it's worked well. Why try to change it, right? But trying to educate and help people understand where the science is going. Because sometimes I know there's this lag between, and we talk about implementation science, like, yes, we have the evidence, but sometimes it takes 15 years to get into practice. But also, if you have data, some preliminary data, like if there are other health systems that have done this, and also trying to share information about how that process was, because people can be hesitant to change when they feel like, well, we don't know how this is going to turn out. So if you have examples of other competitor health systems that have had the same journey and have been effective, that would, but ultimately, talking to the right people, because there are people, who get it, right? And there are people who don't. But for those who don't, I think it's easy to just say, well, you don't, but how do you bring them along in the journey? So I think the polysocial risk score is great, but someone would say, well, we already have the CMS tool, but what we could do is figure out how there might be alignment, right? Because as long as you're measuring the underlying domain, like the wording of the question may not be exactly the same, but if it's asking about the same thing, which is housing instability, it opens up the room for just tweaking things here and there. I hope I answered your question. Thanks.
Thank you so much. Again, I appreciate everyone joining. This is, I would say, you have opened our eyes and imagination on the things that can be done and should be done, and but more importantly, not just pointing out where the issues are, at least giving us some guidance. And I'm saying this is a great framework that not only for hypertension, I'm just thinking out loud, the next frontier, truly obesity, pre-diabetes, diabetes, but that's the way to go. And I think so community engagement, implementation science, and taking and leveraging all the mobile interventions is the future. So thank you so much for joining us.
Thank you so much. Thank you so much, everyone. Thank you.